MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Hey, welcome to the MedBix Webcast. This is Ramana Annamaraju. This is I'm the host. I have an excellent guest today. It's a truly an honor to invite Dr. Richard Allen Williams. He was the great friend of mine. I'm going to say introductory things for him. So I'm going to play a video on the Dr. Williams introductory video. I made it for him specially. So watch that video. This is actually Dr. Then after that, if it's possible, she can get in, the Leanne Meier is going to join from as a nurse from Minnesota, but Dr. Williams is going to join first. So I tell you, this is I worked with the cardiologist quite a bit, extensively around the country. And, one of the things is that, particularly in the minority, the disparities in healthcare, people talk about it, but, Dr. Williams wrote several books on that one. Okay. So it is not only he wrote books, he started a action plan to do the historical plan the Minority Health Institute is an action plan. Actually, is trying to teach other doctors how to culturally sensitive patients how to deal with the culturally sensitive patients. So, without further ado, let me introduce a introductory video, and then I'll bring Dr. Williams online.
My love has come. Hello, this is Ramana Annamaraju. Welcome to MedBix Webcast. Today's interview is with an icon in medicine, Dr. Richard Allen Williams. Dr. Richard Allen Williams, medicine is a true calling. He is putting unrelenting fight against disparities in American healthcare system, particularly for African Americans. This Harvard-educated cardiologist has numerous awards and honors throughout his long distinguished career. He has a long-standing relationship with the Harvard School of Medicine in Boston and UCLA in Los Angeles. He is a recipient of numerous awards that include a Lifetime Achievement Award from Harvard School of Medicine and UCLA. Black Enterprise magazine recognized him as one of the 100 best doctors in America. He is a founder of Association of Black Cardiologists and also served as a president of a National Medical Association, the largest African American physician network in America. Dr. Williams received a special recognition from American Association of Cardiologists of Indian origin and also a friend of founder, fellow cardiologist Dr. Naveen Nanda. On this July 4th, 2020, America's Independence Day, about honor and duty, it is worth noting Dr. Williams served as a commanding officer for U.S. Army in Germany in 1960s. He is a jazz enthusiast and I'm fortunate enough to attend one of his concerts at his house before pandemic. Dr. Williams authored several books. One of his first books, Black-Related Diseases, published by McGraw-Hill, and his recent book, Blacks in Medicine, both are selected by Smithsonian Museum of History, recognizing his seminal work for African American health disparity. The book, Blacks in Medicine, is socially conscious, culturally relevant book, explores the little-known history and present climate of Black Americans in the medical field. It reveals the deficiencies in the American healthcare structure that have contributed to the mismanagement of healthcare in the African American population and examines cross-currents that intersect with the major events, like the ones we are facing now, the pandemic and the racial protests. My love has come along.
That's introductory video from Dr. Williams. Dr. Williams is a good friend of mine for the last 20 years. went to see. I visited him. He's very close to the Michael Jackson's house, actually, in Encino, Dr. Williams' house. And then I attended one of the jazz festival. He's really fantastic. He met my children also. It's a very good friend of mine, family friend. So, like, without a further ado, I want to bring Dr. Williams to the table. Let me do that. Okay. It's just sorry that I don't know why. Okay. Okay, I'm going to bring Dr. Williams to the table. Okay, just a minute. Williams, Richard Allen Williams, welcome to the MedBix webcast. So, congratulations for your recent achievement, Lifetime Achievement Award from the U.S. Presidential Award, a Lifetime Achievement Award. That's quite an honor.
I'd like to show it to you. Here's the medal.
Yes, sir.
There.
Oh my God, yeah, that is beautiful. That's from United States President.
That's right.
Absolutely good. Yes.
And in relation
It's a
to
well-deserved honor.
in relation to that, let me show you a previous award that I received, or actually a gift. This was from President Obama, who sent from the White House this medal.
Can you show that?
Yes, I'm showing it to you. I don't want to unwrap it, but in any event, that's a medal of showing the picture of the White House that I received from President Obama. And I also had received this depiction. I forget what the term is that you call it, of the White
House.
Can't
see much
from President Obama. Origami.
Oh, okay, I see that.
An origami yes, that he sent me as a present.
Origami, oh.
Okay, so I guess you might say I'm walking in high cotton in regards to the
absolutely. It is a well-deserved honor.
Yes.
You have a long history. You're one of the pioneers and a legend in this field. Let me ask you, what is you're one of the things besides being a cardiologist and taking care of the patients, your disparities in health. You wrote several books on disparities of health. What are the disparities of health? Is it disease or care or access or all of them? Can you give us a little bit rundown on that quickly on what are the disparities, particularly primary African American and minority patients?
Let me just cut to the chase and give you a little bit of background as to what disparities in health means. The background is slavery, because during slavery, the slaves were treated in an unbelievably vicious way. They didn't get good food, water, not clean water. They had to live out in the fields, and they developed a number of diseases and so forth. And these things became chronic illnesses, which got into their systems, so to speak, and into their DNA, if you will, and resulted in a litany of illnesses that are passed down to the present day. So that's what we call the slave health legacy or deficit, which led to all of this. It all emanates from slavery and from the mistreatment of the slaves. And so what resulted was a huge difference in not only health status, but health care for Black people in the United States. And that, as I said, resonates all the way down to the present day with disorders, clinical diseases such as hypertension, heart disease, which is the worst in Black people in any group in the country, stroke, diabetes, infectious diseases such as tuberculosis, and on and on. There's so many illnesses that we could recount. Let me simply say that of the 10 top diseases that exist in the United States, 9 of those diseases are more common, more prevalent in Black people. And so there's an unevenness in regards to the disease experience. between blacks and whites, and that's really the main situation that we're dealing with when we talk about healthcare disparities.
My son is also, he's a musician like you. He went to this last weekend. He went to Charleston, South Carolina. He was singing with the Geechee singers, where my ex-wife is from in South Carolina. Geechee songs he's doing along with them. It was quite interesting to hear what the slaves were singing during that time. That is a very special language they use. Even my ex-wife and her sister were talking. I could not understand that language, Geechee. So that's a very quite. It's a slavery. It's a real, and it is really impacted the health of the minorities.
Well, that's interesting. I'm very impressed that your son is able to get into that Geechee culture and understand it and deal with it. I have not been able to, and I don't understand the Geechee dialect or dialogue or the way that they speak, but that emanates from a particular area of Africa. That's where the Geechees of South Carolina come from, and that's their a particular subpopulation of blacks in the United States.
So, Doctor, is it so? You gave me the background to it. What is the affecting at this time? In what areas it is affecting? Care or cost or access? Which one or all of them? Little bit. Can you give them a little bit of each one of them? What is that? The present day affecting the minority population.
All of those things that you just mentioned: care, cost, access, and also what we call the socio-economic determinants of health, which is a new buzz term that's used to describe the environmental and climatic and nutritional and the home health needs of individuals who are black. That's one of the biggest disparities that exist now. As it's said, it's more important to look at one's zip code rather than one's genetic code. If you look at the zip code, you'll find that there's a huge disparity between the health care that's received in certain zip codes, for instance, those that are mainly in the ghettos of the major cities in the United States and also in rural areas, as opposed to those that are in more affluent areas, such as in LA area. And we talk about Beverly Hills and Bel Air and so on and so forth. They get much better health care than the people who live in Watts and Compton and so forth in this area. So those are all very important determinants. The nutrition aspect is perhaps the most singularly important. We happen to have what we call food deserts in ghetto areas where people do not have, for instance, in supermarkets, fresh produce that they can buy or access. And all of these things are important because people often talk about access to care. Access to care is not the most important ingredient in healthcare disparities. It's important. That is, whether or not individuals can seek out and receive medical attention for their illnesses. The most important aspect is what we now know to be the socioeconomic determinants of health. And that's all of these things that I just mentioned: food, water, nutrition, climate, environment, and things of that sort.
Talking about nutrition, Dr. Williams, I was placing physicians around the country. I went to Selma, Alabama. In Selma, one of the doctors in the hospital told me that they didn't have a nutritionist. You see overweight around that area. It's an epidemic, in fact. So the doctor was telling me that they don't have a nutritionist for the last 10 years in the hospital. That is the sad state of the affairs. And that you're right about the nutrition part of it. There is a need for we need to put the resources. So, as you say, the nutrition is important. How can we allocate the resources now according to the disease burden? We can allocate the resources rather than just allocating equal amounts everywhere. What do you think of that? Disease burden is must be considered in the allocating the
Well, that
resources.
all reverts back to your U.S. Congress. And may I say that anything that happens or is going to happen that affects all of these things is influenced by policy. Nothing is going to happen in regards to changing these trends and all of these devastating conditions unless Congress decides and the president's office decides to make an impact by making the changes that are necessary to bring people better socioeconomic determinants of health and to eliminate healthcare disparities.
Dr. Williams is not just nowadays is not just a black population. Now, rural Americans, they are also being affected in Appalachian Mountains and they are also suffering. I think the systemic problem caught up with the problem with the rural populations also.
That's correct. Uh, and we use the term systemic or systematic bias, and that includes bias against not only blacks but other subpopulation groups. And so this bias extends not only to racial identities and ethnic identities, but also geographic identities. For instance, you mentioned Appalachia. That's one of the most uh, poverty stricken areas of our country. And those people are not primarily black. However, they suffer healthcare disparities just like black people do. And we recognize that. We can also look at other ethnic and racial subpopulations, such as the Native American population. Remember that this is November, and this is Native American and Indigenous Peoples Heritage Month. I want to point that out. And we should be focusing on the fact that uh, Native Americans were some of the original people who suffered healthcare disparities and still do. One of the biggest disparities that they suffer is in regards to diabetes. They have a bigger diabetes burden than African Americans do in the United States.
Dr. Williams, talking about disparities, you wrote several books on the disparities, very well received books, very well recognized books. In the one of them is McGraw Hill's. Then tell us a little bit the books you wrote on the particularly on the disparities of the health.
Well, I'll be very brief about it because that's an extensive topic. I've written
Yeah.
I've written 9 books over the course of my career. The first one was what was called the Textbook of Black Related Diseases, which I wrote in 1975, and as you indicated, was published by McGraw Hill, which is the largest textbook publisher in the world. So I was quite honored and indeed pleased to be able to get them as my publisher. That book was 900 pages long. It was my biggest literary work to date, and it covered it was the first book to expound upon what we now know as healthcare disparities and difference in health status among Americans, and focused on the black population, showing that blacks indeed do have a different experience or experience medical conditions in a different way than other people in this country, especially Caucasians.
Your recent book is a Blacks in Medicine. Can you tell us a little bit about that book? The recently Springer published that Blacks in Medicine.
Yes, this is a book that I published 1 or 2 years ago, I guess.
Do you have it, but can you show that if you don't mind? Do you have next door?
If you don't,
Okay, that's okay.
I can show it, but it's going to mean that I have to leave the screen for a moment.
Okay, that's okay. Then you go talk about it a little bit.
Okay,
Yes.
well, in any event, Blacks in Medicine is my most recent publication. It's my 9th book, and it is uh, essentially the history, the 5,000-year history of the Black experience in medicine, which I wrote specifically for the purpose of trying to reveal many of the details that have not been known up to this point about healthcare disparities and how they occurred. And not only that, but also the impact of things like what we call traditional medicine, that is, even things like voodoo medicine and roots and unusual things. For instance, like your son is experiencing with the Geechees in South Carolina, and that sort of thing. And all of that stuff is in my book. But more importantly, it focuses on what we have already referred to as the socioeconomic determinants of health and how those need to be changed in regards to moving the needle of health equity forward.
Dr. Williams, you're not only writing the books and talk about it, you actually sprung into action by starting a Minority Health Institute. What is a Minority Health Institute does? What is their function? Can you give us a little bit about Minority Health Institute?
Well, the Minority Health Institute, or MHI as we can abbreviate it, was the third organization that I founded many years ago. The first one that I started was focused on education of minorities and particularly Blacks in medicine. And that was when I was at Harvard Medical School, and I started this organization to try to recruit Blacks into medical training positions where there were none in Boston, none, at the time that I initiated my own training in 1968, when Martin Luther King was assassinated. In any event, moving forward from there, and that was a very successful enterprise, I then founded an organization called the Association of Black Cardiologists, which you're very familiar with. And that was for the purpose of focusing on the need for more cardiovascular care, better care for Blacks, as well as better training, more training of Blacks to enter the field of cardiology. That has also been very successful, and it's about to celebrate its 50th anniversary next year. And there's going to be a big celebration, which I hope many people will pay attention to. It's going to be in Los Angeles in September of 2024.
Excellent.
The third organization is the one that you're referring to now, which is the Minority Health Institute. MHI, I founded in 1985, and that was for the purpose of trying to focus on teaching doctors the proper approach and attention that is needed by Black patients, using all of the cultural competency emphasis that is necessary to treat Black patients based on their particular and peculiar characteristics. So it was basically a matter of saying one size does not fit all, and that Black patients need to have a different approach in regards to how they are treated based on their particular experiences, which were emphasized in the Blacks in Medicine book that you cited earlier.
You're talking about cultural side of it. One of the mythology myth is that the Black patients have a high tolerance for pain, which is not true. Is experimentally proven that is not true. So is it that kind of a thing? You can make them aware. All the doctors who are treating the Black patients around the country, a lot of Indians, a lot of white Caucasian doctors are treating a lot of Black patients. They need to know this kind of a thing. That's what they. That's one of the things, the educational aspect of it, that Minority Health Institute talks about.
Well, there are a lot of myths that we have to overturn. What you referred to is the higher tolerance level that Blacks have for pain, which is a myth. It's not true. And it is meant that many Black patients who've undergone surgery or have had painful illnesses have not received the pain relief medication that they need for their particular conditions based on that myth. There are others. For instance, there's a myth that says that Black patients have thicker bones and more dense tissue, and therefore, when they have x-rays done, they need to have a higher, what we call kV or kilovoltage, applied to them of the x-rays in order for the x-rays to penetrate that thicker bone. Not true. But
Not
that
true.
has been written in radiology textbooks for years and is still there. Uh, the thought that higher kV is needed. And another one is that Black patients have different kidneys. To some extent, that is true, but it's not reflected in a different physiology in regards to the experience of renal or kidney disease. However, the myth goes that because of this difference in anatomical difference between Black and white kidneys, that therefore the tests that are done to determine the presence or absence of kidney or renal disease have to be adjusted in such a way that uh, they have to be adjusted for race adjusted. And the adjustment leads to less recognition of serious kidney disease in Black people. So if you recognize less serious kidney disease, you're not going to send those patients when they need it to have dialysis. And those patients may go on and die because of the fact that their kidney disease is not appropriately recognized and treated. That's more recently come under review and fire, and many of those paradigms are being changed now as we speak. But those are just some of the examples. I could give you many more.
Yeah, many more. So on the November 9th, you have a special occasion going on in the Minority Health Institute Conference Annual Summit in Los Angeles. Tell us a little bit about it. I can put a poster on it a little bit and show you that what I have, besides all your books and everything about your honors. This is can you explain can you see on the screen that you are with some people, that who are those people, and then some of the speakers who are coming to the Minority Health Institute on November 9th.
Well, it's very kind of you to put this up. That helps tremendously. And what you're showing is in two parts. The first part on the left shows my receiving the Presidential Medal, Lifetime Medal of Achievement from the Biden administration. And the two people, the presenters, are there with me. That happened just this past Saturday in Atlanta. The image on the right depicts the flyer for the 6th Annual Minority Health Summit, which I've organized here in Los Angeles, and that's going to take place on Thursday, November 9th, exactly a week from tomorrow. And we hope that people will avail themselves of this fantastic conference. It features some of the biggest leaders in healthcare and in attacking health inequities in the country, including the leader of the National Medical Association, Dr. Yolanda Lawson, who is giving our keynote speech. She's at the top of those pictures that you see there on the right.
You were the president yourself, and you are the 117th president of the CM Association, right?
That's correct. But this is going to be a fantastic event. It's a nationwide event, which is being held in Los Angeles. And we encourage people to register for it and to come to visit and be there. However, if you can't be there physically, you can be there virtually because it's a hybrid program, which allows you to tune in on Zoom and take part in this this 6-hour program, and you can take any part of it that you want once you register, etc. but it's going to be fantastic. And the whole purpose of this program, I must emphasize, is to try to bring more meaningful dialogue to this whole question of uh, the need to establish health equity in this country. Health equity means equal, not just equal, but equitable treatment and healthcare delivery across the board to everybody. Everybody has a right to the best healthcare that they can achieve. And unfortunately, minority populations and communities of color are not receiving that. So this is an effort to try to bring attention to that situation. And we've got a number of people, as you can see at the bottom of that panel, who are sponsoring our efforts to do it. The biggest sponsorship will come from the individuals who attend either in person or virtually to this very important conference. Again,
I put a website there, mhinstitute.org. If you see that in the bottom of your screen, so they can kind of go to the website there, minorityhealthinstitute.org, right? mhinst.org.
that's correct.
So, who are the other speakers? A couple of other speakers you can mention, notable speakers besides President of the National Medical Association.
Well, we have the president of the Medical Board of California, Dr. Randy Hawkins, who's going to be speaking, especially talking about uh, the importance of diversity in the workforce, the physician workforce and the medical workforce. That's extremely important that we focus on the need to train more Black and other minority physicians, which we're not doing now. We're way down in regards to the needed numbers. So Dr. Randy Hawkins is going to be one of the speakers. Dr. William King from Los Angeles, who's a specialist, an internist, and a specialist in HIV/AIDS treatment, is going to be giving a fantastic lecture, I'm sure, which has to do with conquering HIV/AIDS in the minority community. And we've got so many others. We even have speakers coming from as far as Johns Hopkins University in Maryland, who will be here to speak. And also, we have Dr. Carol Watson, who's one of the most outstanding uh, physicians, not just Black, but any kind of physician in the country. Dr. Carol Watson is the director of the Barbara Streisand uh, clinic at UCLA for women, cardiovascular clinic for women, and is very highly esteemed cardiologist in this country. And she's going to be speaking on Black women's heart health, things of that sort. So
It's going to be a fantastic day,
really going to be a
absolutely.
fantastic day.
Dr. Williams, so just before I leave, I'm interviewing after this. I'm going to talk with a nurse from Minnesota. Tell me a little bit about what the nurses' contribution to the medicine. Are they are kind of biased? So, what do you think of the contributions by nurses to the
Oh,
to the care of medicine?
my goodness, I'm glad you brought that up. That's extremely important. So when we talk about healthcare, we're not just talking about doctors. We're talking about the whole spectrum of healthcare providers, everybody from technicians uh, all the way through to physicians at the highest level. And nurses certainly fit in there as being extremely important in the mix. Um, we have a school of nursing, the Diamond School of Nursing at the Charles R. Drew University of Medicine and Science here in Los Angeles, in Watts, which is dedicated to training nurses who will operate in the minority community. And that's something that we desperately need because we're way down on our numbers of nurses. And as you know, nursing care is really the essence of patient care, not only at the hospital level, but in offices and so on and so forth.
Thank you, Dr. Williams. It's truly an honor. It's a congratulations again for your U.S. Presidential Lifetime Achievement Award. It's quite an honor. You can show that again one more time, last one.
Be
And
happy to.
eh, the oh yeah, that is a beautiful award. Congratulations again, Dr. Williams. You well deserved honor.
Thank
Thank
you
you,
so
sir.
much. And I'm
Thank you for taking time to talking with me. Long time friend you are. Thank you so much.
quite proud of talking with you and of receiving this award and of continuing to do this very important work, which I intend to continue to do with surgical precision. Thank you so much.
How do you like, one more time, I wanted last question to you is, how do you like my program that I'm doing nowadays?
Oh, I
What do
love
you
it. I
think of
think it's
the,
very, very important, very essential. Just hope that people continue to tune into it. I've heard good feedback for it, and I want to encourage you to continue on. And anytime I can be of help, I'll be happy to be.
thank you, sir. It's a total honor and privilege.
My pleasure.
Thank you, sir.
Thank you.
Bye-bye.
Bye-bye.
Very good. Thank you so much, Dr. Williams. It is an extraordinary interview by Dr. That's he won the several awards, but this is the top of the award. That is the from President Biden, and he won the awards from the President Obama. He is a truly hero in my books. Next is actually he was talking about the nurses. I asked about a nurse. I'm going to talk with the Leanne Meier from Minnesota. She's going to join. She's a podcast host. She worked as a nurse for 50 years. One time I interviewed one of your colleagues, John Silver. He was giving us some kind of a new model. They are the closest to the care system. Doctors come and see patients, but the nurses are always there. I think you need to have in the particularly we realized it during the pandemic, the importance of the nurses in the pandemic area. Leanne Meyer is joining from, I will ask her a background a little bit. She can give me a little bit of her background. Let me bring her to the table. Hi, Leanne.
Hi.
Welcome to the MedBix webcast.
I am so thrilled to be here. And I'm really thrilled to be on this show with Dr. William. I had not heard of him before, and I am absolutely in love with him. Everything he was saying is exactly what we have been working on and what we are wanting to accomplish with our Nurses Transforming Healthcare. So he's amazing.
Just give me your background a little bit, a personal and professional background a little bit. Quickly, and see. Sure. Then after that, I will ask you a couple
of
questions.
I have been a nurse for 50 years. I've worked in every area of hospital nursing. Had one stint in a spine care clinic, which at that time I was very, very injured and was not able to continue to do. So I went from there into teaching, and I absolutely loved teaching nursing. I was teaching nurses returning to nursing after a period of time away. And I was so impressed with these nurses. Just some of them had been away from nursing as long as 30 plus years, and they were just phenomenal nurses even yet. So that's and then I'm supposed to be retired now, but I am working harder than ever. Mm-hmm. So the Once a Nurse, Always a Nurse has been, I've been doing that podcast for since 2017. At the peak, it was 120,000 listeners in 70 different countries. I was the first nurse, apparently, to do an international talk show for nurses. So I didn't even know that when I started it. And then Power Up Nursing was something that I had a dream to be able to help nurses understand they have so much more power than we give ourselves credit for. And so that dream has come true through a friend that is a marketing whiz. And then also 2 years ago, I think we're coming up on 3 years ago, that I started doing Nurses Transforming Healthcare. And that came directly out of the Once a Nurse podcast that I was doing. I met Dr. John Silver, who came up with an amazing economic and healthcare model that is exactly in tune with what Dr. Williams was saying. And then Kim Evans, who is an advanced practice nurse and wrote a book called Transforming Healthcare, Healing You, Me, and Our Broken Disease Care System. And then the final person was Kathleen Bartholomew, who is most well known for the nurse-to-nurse hostility, in improving communication between doctors and nurses, etc., and learning civility in our professional life. So those are the 4 people from Nurses Transforming Healthcare. Together, we have over 100 years of experience.
Yeah, no, Leon, you have a nurses transforming healthcare. Before we talk about that, I wanted to ask you autonomy of the nurses. A lot of states now, nurse practitioners can deliver a lot of care. They can prescribe medications. They can order tests. So do you think that we need a more autonomy to the nurses in not only in the United States and other parts of the world? I heard something that in New Zealand have a lot more powers to they have a lot more autonomy there. You think we need a more autonomy in every state now, and then plus in other countries also?
Yes, that's a short answer to a long question, but absolutely. And Dr. Williams addressed it just a little bit. Doctors and nurses address health and healing from 2 very different points of view. And for the most part, people know what doctors do. There's plenty of movies and TV shows and people even going in and experiencing doctors, but people don't really understand what nurses do. And sometimes nurses don't even understand what nurses do to the full extent. But yes, the nurses that are trained for advanced practice nursing, nurse practitioner, doctor of nurse practitioner, there's several different categories, but they all are trained to do primary care nursing, primary care, healthcare. And there is no reason that they need to be under the prescription of a doctor. That is something that the doctors wanted to have happen because they wanted to have control over nurses. And that's kind of been what's been happening for a long time. So yes, I think, doctors come at healthcare from a problem-oriented perspective, and nurses come at healthcare from a very holistic. They want to take time. They want to listen to their patient. They want to, learn everything they can. They have somebody who comes in with symptoms, but are those symptoms really the crux of the problem? Oftentimes it might be, say, somebody comes in with abdominal pain, and in the course of talking and listening to the patient, they discover that the man's wife just died 6 months ago, and this pain all started since then. So, somebody who was cared for by his wife, and suddenly he's trying to deal with everything, making meals, buying groceries, all those things that women had done, and maybe even just that lifelong companion. So when you just deal with the symptoms, you're handing over a medication for, to prevent stomach acid. But if you're really hearing what that person is saying, it's probably more they're in mourning and they don't know how to deal with it and they don't know where to go with it. So having somebody hear them is what they really need.
Leon, I kept on hearing from nurses only, I hear from doctors, but mostly nurses talk about prevention. They are very focused on prevention, and I think that is one of the wonderful things. Tell me something about why nurses that understand the prevention more.
Well, it's really common sense. What we have set up right now is a system that is focused on disease care. And so because of that, that's where the money is. That's where the focus is in most of the medical community. And that means that we're not going to focus on, in fact, there are some places where they're just almost completely getting rid of primary care. But it doesn't make any sense. If we're going to wait till somebody has very severe chronic problems, the chances you're going to cure somebody at that stage is pretty slim. So then it becomes an ongoing dealing with this chronic and very expensive kind of healthcare. But if we're looking at the preventive and the primary care, we can help at the very earliest point of helping people understand what they can do to maintain their health and to not get into disease situations, or to recognize very early on what is going on and that they need some help. And like Dr. Williams said, oh my gosh, I mean, everything he said was so perfect. Having access to care is important, but the most important thing is that we're focusing on the social determinants of health. If we're trying to deal with a person who is having some kind of a chronic problem, but you are not finding out, do they have a house? Do they have food? They have good food. He talked about the food deserts in many of the African American communities. All of those things, if you do not have those most basic things, it's going to be almost impossible to deal with that chronic problem, because they won't be able to get to their clinic appointments. If they do, they will almost assuredly put them right into the hospital. So they get hospital care, they dump them out, they don't have any place to go. They don't have any way of getting to a pharmacy and getting the medications that were just prescribed for them. And so they go right back into the same situation they were in, and it becomes a vicious circle.
So that is the social determinants. That's what, with your colleagues, John Silver and other people started it, is a public utility model where they're taking care of everybody, takes care of it. Can you explain a little bit of a public utility model, a little bit, what we are all trying to do?
Yeah, kind of just briefly. John got this idea. He had gone around the world to try and find an economic model and something that would focus on good health outcomes. And he didn't find anything. So he came back to the United States, and he found in history, back in the 1930s, President, my brain just went dead, in the 30s, who was President Roosevelt, was dealing with, it was kind of the same sort of thing as we have now with the internet, where the internet companies are very happy to bring them to the cities because there's so many people, and it's a great impact dollar for the efforts that they're putting in. But they don't want to take them out to the small towns, to the rural areas, to farms, because it's a lot of money to get that out to them, but then not very many people utilizing it that they get a lot back. Same thing with healthcare is what happened in the 30s was it was used. This idea of public utility model was used for electricity. So back when Edison and some of the other companies that were getting electricity to the cities, they didn't want to take it out to the farms. They didn't want to take it out to the small towns because it cost them way more money than they could get back. So what Roosevelt said is these things, to have electricity, to have good water, having sewer systems, all of those things are a public need. People need these things to be healthy. And to be healthy, we have to have good care that, like he said, addresses the individual from their point of view. So you can't just treat everybody all the same. You have to understand who is the person in front of you and be able to speak to what they can hear about health. So basically, it makes sense to us that if you can have water, electricity, sewer, all of those things as a public utility and a basic need, why not have healthcare on that same list? So that everybody would pay something, a very small amount compared to what we're paying in now, and then it would be contributed to by, city, county, state, federal, would all put something into it, but nowhere near what we're putting into it now, because of all the high costs of healthcare.
Yeah.
Does that answer your question?
Our healthcare system is not working at all. I mean, public health system, that you're trying, you're taking a big boy you're trying to eliminate insurance companies. That's that is a big challenge itself.
Yes.
But
Well, we're not trying to fight them. They can go and do what they're doing. We're setting up something that works so well that it will make what they're doing obsolete. And so it won't happen in my lifetime. It won't happen in your lifetime. It could be a very, very long time before all of that comes. But the point is, most of those people who are flooding away from the disease care system that we have set up, they're looking for something like this. This is the kind of healthcare they want to do. So you had Dr. Todd Otten on a week or so ago, and that's exactly what he was saying. He was dying in that system that was all about making money and not about letting him use his knowledge, his expertise, his wisdom to help that person in front of him be healthy.
I have the nurses are not just, as you say, that's just providing a care and taking care of the patients. They also excellent administrative. One of them is Florence Nightingale. I did a show on the Florence Nightingale. She is one of the symbol of people take a Florence Nightingale pledge. All the nurses, that she did. She's a mathematician. She's an epidemiologist. She's close to the care. She understood the patient's problems right on the spot, and then she's closest to the care, and she understood she even designed the hospitals.
Yes.
Scientific American made a tribute to her, writing about she's the first architect of the hospitals. So the nurses play a very critical role, not just providing and taking care of the patient. They do certainly that, but it's also they provide insights into the care system itself. And what you're doing is don't give up. In your lifetime can happen. The changes can come down, because Florence Nightingale is an example of that. She made a big changes in the system.
Yeah, she was amazing. In fact, I have it here. I don't know if you can see this.
Yes.
This is a book called The Florence Prescription. And it's written by a friend of mine, Joe Ty. And it's wonderful to really help you understand all of the things, or not all of, but a lot of the things that Florence did back in that time. And where she started really making a difference was in Scutari hospitals. And that was in the Crimean War. So these were the cannon fodder, basically. The way the generals worked was that there were always, more people to bring in, usually people out of the gutters or whatever, is just throw them at the cannons and, hope that they overcome their enemy. There's a quote in here that I thought was interesting. It's from Queen Victoria, and she was lamenting the incompetence of her military leadership during the Crimean War. And she said, "I wish I had Florence in the War Office." And so what would happen is the generals would come and complain about Florence, butting into what they were doing. They were basically, if somebody was injured or hurt, they just kind of got thrown off to the side. And Florence came there to try and help. She organized, she realized that these people were living, laying in filth.
Yeah.
They needed to be cleaned. They needed to have beds. They need to have water and, hope. What kind of hope can you have when you're just laying there in filth and nobody's really attending to you? It was just one person stacked right beside another. And she got the generals to build her a hospital, and she those men loved her, because most of them that survived were strictly because of her. Again, what she did was social determinants of health. They needed to have a place to be safe and warm and comfortable. They needed to have water, food. They needed to have their waste taken away. All of those things she addressed.
She was the first one to address the medical disaster. Is not the people that she said that she argued with the mathematics and statistics. She invented the pie chart, kind of a road chart is called. And what she argued in that chart was that people are dying with the disease more than a war itself. And that's a
Exactly.
it is really educational to me personally. I thought that is one of the eye-opening things to the Queen Victoria. So she said that, what she said was very interesting. Florence Nightingale said that not Russians are not killing in the British people in the war. Actually, the British politicians are killing the British
Yes,
people because they're not taking care of
exactly. And
themselves.
nothing has changed, right? We're
Yeah.
still right back with politicians
Yes, that
thinking
is.
they've got the answers, and more cannons, more armaments just doesn't seem to be doing the trick.
We need a definitely, that is the input from the patients, doctors, nurses are very critical to change the reform in healthcare. Without people like you, we cannot have the reform, a meaningful reform. Thank you so much, Leanne. It's a truly honor to talk with you. It is a wonderful, it is educational. Say the final words, anything you want to say. I would love to hear from you.
I love nurses. I love being a nurse. I want to talk to as many nurses as I can. I want them to understand that even though things look very bad right now, it is like one of those juxtapositions that we are in the greatest opportunity right now to change the direction that healthcare has been going. And nurses, 5 million strong of us, I believe we're the ones that really will be able to turn this, because we're still the ones that are very much focused on the patient, whereas the people that maybe are at a level above us have more financial incentive to keep things the same.
So
Nurses
the
don't
last one,
want
I want to talk with you about the international. Tell me how the international nurses are all connected together. You're doing a lot of connections there. Just give us a final word on the international.
Yeah, we are trying to connect. In fact, nurses internationally are connecting to us. They're hearing about us and they're connecting to us. In fact, there's a lady in India that I am so impressed with. She has the same goal for India. And we have Australia and South Africa, Canada. There's many people in Canada. And so the reality that I'm learning is that the problems we're seeing in the United States are not just here. They're actually all across the world. No matter what system of healthcare people have, they're still having problems really understanding how do we get healthy people and keep them healthy. What we're doing is going in the wrong direction. And what we think is that healthcare right now is a train going 200 miles an hour in the wrong direction. And we want to create switch tracks that take it back to the direction that will really work.
We need voices like yours, a lot of them like you. Thank you so much talking with me, Leanne Meier, joining with me.
I want to thank you because you are a very patient man. Thank you so much.
No, I'm not. Sometimes I get frustrated with the technology. So thank you so much. But you did a fantastic job. It's a very educational for all of us. It is truly an honor to talk with you, Leanne.
Thank you. I am thrilled to be on with Dr. Williams. If you can connect me with him, I would love to have a connection with him. He's
Thank
wonderful.
you all. Good night, guys. Good night.
Bye-bye. Thank you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.